10 years ago, I was diagnosed with prostate cancer. And at the time, I had myself treated with an unusual procedure called a focal cryoablation. This was only given at a very few places, maybe 5 places in the US, but it was approved by Medicare as an initial treatment. And I had it done at NYU Langone. Originally, I was being treated at Penn, but had a very, very bad encounter there with the urologist who examined me on a last patient on a Friday afternoon. Never a great spot, by the way, to get in to see a busy doctor who's probably had a hard week. So I decided to leave Penn and go up to NYU, which at that time was not. It was highly rated, but it wasn't as highly rated as it is now. Now, by U.S. news standards, I think NYU has risen to number 2, tied for number 2 spot in urology. At that time, it was, I think, 8th or 10th or something like that. And so I think that, my choice was a good one. And Dr. Samir Taneja was the person who treated me, and I'm eternally grateful to him for having done so and taken me on. My prostate cancer was of a rather advanced local stage. In other words, I had 2 large tumors and some smaller tumors, and it was what's called a Gleason 8, which, or for those who are familiar with the terminology, that's a measure of the aggressiveness of the cancer. And I think that 10 or 12 is the maximum that you could be, maybe. And most men have Gleason 7, and then there are subcategories of that. Mine was what's called 4+4, meaning that all the main configuration of the cancer cells was in an aggressive form. And so it was rather unusual to even take me on as a patient to treat me with this just hitting the main tumors themselves and not the entire gland. So this seemingly was effective, and here I am, alive and feeling well 10 years later, but the cancer has come back. I can't pinpoint exactly when that happened. I think it started to come back during the COVID pandemic. I can't be 100% sure of that, but I've had the prostate-specific antigen, or PSA, test done at least annually or throughout that time. And I could see, and I keep a record of that, and I could see the gradual change. It was down in, the PSA was in the 2s right after the procedure, but then it rose up to 3-ish, and it stayed in the range of 3 to 4 for most of the next 6 years or so. And then during the pandemic, it started to rise rather slowly, and then finally broke through each of the points, the danger points. It got above 4, and today it's slightly above 7. So it's been this sort of gradual but persistent rise of the PSA in a troubling way. So last year, about almost exactly a year ago, I asked Dr. Taneja to do a more thorough diagnostic workup. I had people advising me not to worry about the PSA. Somebody who's very, very knowledgeable in this field was telling me over and over again, PSA doesn't matter. It's just a measure of the anxiety or cause of the anxiety of the patients and so forth. But I couldn't ignore it. If it had just stayed at 6, let's say, and not moved, then perhaps I would have been inclined to go with that. But obviously, if it just keeps rising and rising, especially if the rate of increase is significant, then you have to pay attention to it, or else you're being foolish. You're just sticking your head in the sand. So over the past year, I've gone through all of the main tests that one would take in order to find out whether this is a malignancy, and if so, where it's located, how many, how bad it is. And I'm trying to remember exactly what the sequence of events was, but I think that I had the MRI was first, and that was just March of 2024, I believe, and that showed for sure that there was cancer there. I also had another advanced test called a PET-CT, but unlike almost every other cancer, the PET scan in prostate cancer uses a different agent than the usual one that's used in other kinds of cancer. It's called PSMA, and that's more accurate because prostate cancers don't generally show up very well on PET scans, but there is another kind of test that they use to localize the cancer, and indeed it showed that it was an aggressive cancer. Again, not quite as aggressive as the first time. In other words, the Gleason score now was 7, but it was an aggressive kind of 7, and there were two main areas of tumor in the prostate, and then there were 2 minor areas. So what seems to have happened, and again, this is a matter of debate, but it seems like this was more persistence of disease rather than a recurrence of the disease. Plus, what confuses the issue is that most men who have treatment for prostate cancer in a conventional setting are going to have either surgery or radiation, and those overwhelmingly are directed at the entire gland. And you surgically take out the whole prostate, or you irradiate the whole prostate. So when you have a recurrence, it has a somewhat different significance than what my situation is, because I knew that we were leaving behind. Dr. Taneja and I discussed this and knew that he was leaving behind some cancer cells, maybe even some small tumors. And I think it's pretty light, and the scans show this, that the tumor arose in the area adjacent to where he had treated with cryo, which is cold probes, as opposed to radiation. So it came back. It grew out. It was a persistence of the disease rather than a recurrence in an area that had actually been treated. That may not make much difference to, you still have to deal with it. But to me, it makes a difference because, excuse me, I don't feel that the treatment failed so much as it was not complete enough. Now, that's not his fault. I asked him to do that because there are consequences to treating the whole gland, and it has both urinary consequences and sexual consequences, and neither of which I was, looking forward to. So for me, it was a great treatment, cryoablation, but it lasted about 10 years, 9 or 10 years, and there was this slow rise in the PSA over the years, and it has to be dealt with. So that's how I got to the point that I'm at. And then I had to make a choice of whether to do another cryoablation, which I always thought would be what I would do, or else look into having either surgery or radiation, neither of which thrills me, but those were my basic options. So Dr. Taneja did offer, if I wanted to do a repeat cryo, but there were a couple of caveats with that. First of all, as I discovered to my dismay, Medicare wouldn't pay for a repeat cryo because they consider this to be a recurrence of the cancer, and they feel they don't have enough evidence or information to be able to justify doing it again if it failed the first time. But that didn't really address my situation. But this was, as I said, I think this is more a persistence of the disease than a true recurrence of the disease. But I was informed that they wouldn't pay for it, in which case NYU did offer to do this on a pay-as-you-go, as a private patient basis. But the cost of that was very high. I think it came out to about $27,000, and that was considered to be sort of the bargain rate, because if I went into the hospital, I was told it would have been, I think, about $50,000. So it was supposed to be 25, and then it immediately went up to 27. And then I got a note saying that the anesthesiologist may charge more if the procedure went on over an hour or so. So I felt like this is like I'm getting in over my head financially in terms of this. But if I could have been assured that this would have cured me without any additional side effects, then I might have, considered it. There were relatives who were willing to make a contribution and so forth, but I felt really bad about that. I feel like if it was a really good treatment, then the government, the Medicare, and my supplemental insurance should pay for it, but that was not going to be the case. So the other thing was, I didn't feel that there was adequate documentation of the effects of that treatment in cases of recurrence or persistence of disease. I'm a little disappointed in the lack of published studies over the last 10 years on this method. It's a good method. It's a very exciting development to freeze cancers instead of just totally destroying them. But I feel there should be more in the way of documentation. And now Dr. Taneja is leaving NYU, I understand, as of this month, and going to a very excellent position for him. But I think it also put the whole field of cryoablation for prostate in something of a suspended animation, as it were. I don't know if anybody knows where it's going to go from here, but this would have affected me also because, treatments, especially invasive treatments, they have consequences, and you might have side effects. You might need retreatment, who knows, so I like there to be some continuity of care. And I got a feeling in my discussions with him, and again, no criticism is meant or intended here, but he mentioned several times the option of doing radiation instead of doing the cryo. So I didn't feel, the whole thing didn't add up to me to be the sort of exciting, cutting edge, new thing that people were really energized about the way that it was 10 years ago. So I still was scheduled to have the cryoablation, but I had these just internal gut feelings, as it were, that this was not really the right treatment for me. And when you have those kind of feelings, and to me, it was oddly enough, I'm not a mystic or a psychic, but I had a dream that I couldn't even remember exactly what the dream was, but I remember, upon waking up, that my sort of subconscious message of this was not to do the cryoablation. Well, I kind of, laughed at this and kind of ignored it. And then literally the next night, this exact same thing happened. I had another dream. I woke up again, and again, my subconscious mind or my conscience was telling me not to do the procedure. And I feel like, all right, I'm not driven usually by dreams, but twice in a row, I had this, my subconscious mind was telling me, no, there's something wrong here for me, and I don't want to do it. And then, as I said, I might have been the last patient that Dr. Tadeja treated at NYU, because he's leaving like a week after the time that we had scheduled for me to get the procedure. And then they sent me the bill, or the request, for $27,000. And, this was already, I had decided not to do it. So that was that. I informed them of that. I thanked them, as I continue to thank them, for their wonderful care that I got from them. But, I was free of that. And the minute that I decided not to do that, I felt like a big relief. And I started to investigate what's available to me locally. I have another close relative who's undergoing a totally different situation, a different kind of cancer, but had a good experience at a more local radiation oncology center that's about 10, 15 minutes from my home. So I went there, and I talked to a local urologist, and then I talked to the rad-onc, the radiation oncologist, and was very favorably impressed with them. I mean, they don't know who I am in terms of my online presence and the fact that I've written 12 books about cancer. I mean, I don't put that in people's face, especially in my own medical situation. So I don't think I got any special care from them on account of that, good or bad. But basically, they gave, each of them was very forthcoming. It gave me a lot of time. They didn't seem rushed or anxious or self-centered or anything like that. They really were giving, and what they said made sense. Basically, they operate within what are called the NCCN guidelines, which is the National Comprehensive Cancer Network, puts guidelines for every kind of cancer. These are used all over the world. Even when I went to China, they were some years ago, they were using the NCCN guidelines. So I understood what their strengths and limitations were. And I decided the choice really came down to two kinds of radiation, the intensity modulated radiation therapy, or IMRT, or the stereotactic body radiosurgery, which is a somewhat more innovative form of radiation, and has some links, by the way, to what was once considered alternative medicine, because it was very unconventional to give this stereotactic kind of radiation to the body. It was used for a long time to treat brain cancers, but not so much for the body or for the prostate. So I have a certain affinity, if you will, to the SBRT. But the big difference there is, as far as I could understand, what I've read and what was being told to me, that the SBRT is given over 6 days, I think, 6 to 9 days, and the IMRT is given over a period of 45 treatments, 44 or 45, depending on how you want to define it. So on the face of it, you would think that SBRT would be more desirable. The outcomes are about the same for the two different kinds of treatment. But since I make my own hours, I'm basically self-employed, and also the treatment center is only 10 minutes or so from my house, I was in no rush. I mean, because when I was thinking about being treated at NYU, and they also offered me that as another option, was to get the SBRT at NYU, I wanted to get it over with as fast as possible. I don't live in New York. And so I'd have to be imposing on relatives or staying at a hotel, and you basically want to get it over with quickly. But I have my doubts about that. That economy of time and maybe of money wasn't really my first consideration anymore. So I discussed this, of course, with the radiation oncologist, and his feeling was, and again, I haven't independently verified this, but that the attractiveness of SBRT was in that it's practical, and you have the treatment done in a short while. But it really was introduced in Europe as a way to minimize costs of treatment. But, I think what's more important to me is effectiveness of treatment, which, as I say, is about the same as with the IMRT, and also the question of side effects. That's the main thing on my mind, naturally. And so I've done with him and with the urologist, I've done one big thing to prevent side effects, and I'll describe that in my next video. But basically, I start I have sort of the dry run of the treatment in a few days on Friday, and I'll keep you informed about how that goes and what that's like, because I don't think too many people have done that, and I think people would who are facing this decision or love somebody who's facing this decision needs to know at least how one person is handling that. And I have a lot of thoughts, of course, about questions relating to supplements. I have some definite thoughts about that, how that food supplements relate to the treatment, good or bad, and also how I'm coping with, some of the side effects and how you can avoid them. So it should have some practical importance for people. Well, till next time, this is Ralph Moss.